for inviting me to discuss on the role of extended adjuvant chemotherapy in endocrine non-responsive disease. And there is, in fact, biological rationale for expecting a benefit of longer duration therapy in the subgroup of patients with ER-negative tumors, because these tumors have a rapid cell proliferation, high expression of the proliferation-related gene sets, therefore might be more responsive theoretically to chemotherapy. And also they have a high risk of relapse despite the use of adjuvant chemotherapy. However, when we face with studies discussed, developed in the past on the duration of adjuvant therapies, we have to face with the fact that in the past, studies were designed according to the stage of the tumor, and therefore they included both luminal A, luminal B, non-luminal disease, and therefore afterwards studies were not enough powered for the outcome question in subgroup of patients, endocrine non-responsive versus endocrine responsive disease. Also, we have to face with different cutoff and methodology used in the definition of steroid hormone receptor, femtomoles, immunohistochemistry, 1%, 10%, and also some problems with the reliability of these methods used. And also, there is the problems that today endocrine non-responsive disease is recognized as an heterogeneous groups of tumors that include, for example, HER2-positive non-luminal disease where a targeted prolonged therapy was developed during the past years. One of the major questions in the previous study was about prolonged duration of chemotherapy, more than about 6 months of chemotherapy. And these are the results of the overview published in 1998. And as you can see in the upper part of the slides that compare longer versus shorter duration therapy, there was no clear evidence of an advantage for extended adjuvant chemotherapy. And several of these studies, in fact, use a very prolonged regimen like the SAKK study, 24 months of adjuvant chemotherapy. Subsequently, another meta-analysis was published on about 6,000 patients randomized in studies of longer versus shorter chemotherapy. Median duration for longer was about 10.7 months and for shorter 5 months, and again, no evidence of an advantage for longer duration of chemotherapy with an hazard ratio for recurrence rate of 0.95, not statistically significant. Probably the most important question today, however, relied about the duration within 6 months of chemotherapy. In other words, is enough to deliver to these patients 2 months, the minimum of chemotherapy, like AC, TC times 4, or the more frequently used CMF times 3, or a more prolonged regimen like the 4 courses of anthracycline followed by 4 courses of taxane, for example, or the slightly more prolonged regimen that included in the big 298A for 3 courses, followed by docetaxel for 3 courses, followed by classical CMF for 3 courses. Well, again, when we deal with trials that examine different duration of chemotherapy, regimen differ in the duration of therapy, but also in the schedule and the drugs given. And therefore, in this trial, the effect of duration, choice of drug, and endocrine effects of chemotherapy are obviously confounded. And this trial reached varying conclusions about treatment duration. In example, this is a comparison in NSABP B23 of classical 4 courses of anthracycline-containing chemotherapy with 6 months of CMF chemotherapy. These are the results in the B23 that was dedicated in not-negative, ER-negative breast cancer. No evidence of a difference for prolonged chemotherapy if compared with a shorter regimen that, however, included different drugs. And the issue of dose of the drugs and schedule use is important when also we deal with dose-dense chemotherapy. These are the results of the intergroup study that compared dose-dense versus conventional chemotherapy as adjuvant treatment in not-positive breast cancer. And there, the duration for dose-dense chemotherapy ranged between 14 weeks to 22 weeks, whereas the duration for classically delivered chemotherapy ranged between 21 weeks and 33 weeks for the sequential use of doxorubicin, Paclitaxel, and cyclophosphamide. Overall, this trial demonstrated an advantage in terms of disease-free survival and overall survival for dose-dense chemotherapy compared with the classically derivative chemotherapy. And most important, in a subsequent meta-analysis, the magnitude of the effect seems to be larger than shown here in the lower part of the slides in the subpopulation with ER-negative disease. Therefore, duration of chemotherapy might not be an issue when we use a dose-dense fashion delivery of chemotherapy. And this data should be taken into account also when we analyze the results of the CALGB study, where a slightly different regimen in terms of duration was compared, 6 courses of AC or Paclitaxel versus 4 courses in women with 0 to 3 positive axillary nodes. And then shown here, the vast majority of these patients received chemotherapy in a dose-dense fashion. In fact, after 2003, all treatment was administered in a dose-dense fashion. And again, this study, there was no clear evidence of an advantage for prolonged chemotherapy if compared with a less short delivery of chemotherapy. The figure, however, might be different when we compare regimens that are quite similar. This is an example in the FASG trial, premenopausal, not positive breast cancer patients. These patients were randomized to 3 courses of FAC75, 3 courses of FAC50, or 6 courses of FAC50. And there was an advantage for prolonged duration of chemotherapy if compared with 3 courses, although no evaluation according to steroid hormone receptor was performed. The IBCSG Trial VI also evaluated the same regimen delivered through a different duration in premenopausal, not positive breast cancer patients. And there are patients randomized to 6 courses of initial CMF versus 6 courses of CMF, followed by 3 courses of reintroduction CMF versus 3 courses of initial CMF versus 3 courses plus 3 courses of reintroduction CMF. Overall, there was no advantage for the reintroduction chemotherapy. Results were evaluated also according to a pre-planned analysis according to steroid hormone state receptors. And there was, you can see in the right part of the slides, a poorer disease-free survival for those patients with ER-negative disease that were randomized to a shorter duration of chemotherapy, 3 courses of chemotherapy compared with the others, with an hazard ratio of 1.45, which was statistically significant. There might be also a correlation between the timing of delivery of chemotherapy within the first 6 months after surgery and the benefit of chemotherapy. During the past year, several trials addressed the issue if a treatment gap during the first months of chemotherapy might improve therapeutic results through the recruitment of dormant cells into an active phase. And the IBCSG Trial 1393 is one of these trials. 1,300 patients were randomized to gap, 16 weeks gap versus no gap after 2 months of anthracycline-containing chemotherapy. Overall, there was no advantage for the gap versus no gap, but in an exploratory analysis, as shown here, again, the right part of the slides, the hazard ratio for disease-free survival was significantly higher for the subpopulation with ER-negative disease during the first 2 years of follow-up. And these results supporting the hypothesis that in order to maximize the results, chemotherapy should be delivered continuously for the first 6 months after surgery. The intergroup study, also a very large study, addressed the issue of 4 courses of Paclitaxel chemotherapy after 2 months of anthracycline-containing chemotherapy. This was a 3x2 factorial design, the dose of doxorubicin, the introduction of Paclitaxel after 2 months of chemotherapy. And overall, there was an advantage for the introduction of Paclitaxel, but a subsequent analysis performed on about half of the patients, including the trial, found an improved disease-free survival for those patients with estrogen receptor negative tumors randomized to Paclitaxel versus no Paclitaxel, both in the subgroup of patients with HER2 negative disease and the subgroup of patients with HER2 positive disease. And it is noteworthy that the larger magnitude of the effect was observed during the first 3 years after surgery, which coincides with the higher probability of relapse for ER-negative tumors. 2 other studies from NSABP evaluated the role of extended chemotherapy with different agents after 4 courses of anthracycline-containing chemotherapy. There's one in NSABP B28, AC versus AC followed by 4 courses of Paclitaxel. The other is B13, 4 courses of AC followed by docetaxel for 4 courses versus AT for 4 courses versus ATC for 4 courses. Both studies show an advantage in terms of disease-free survival for extended chemotherapy if compared with shorter duration of chemotherapy, and the NSABP B30 observed also an advantage in terms of overall survival for sequential chemotherapy if compared with AT chemotherapy. And no interaction was found between the effects of chemotherapy and ER status of the patients. The figure is a little bit different when the difference in duration between the regimen is lower. In fact, these are the results of IBCSG dedicated to HER2-negative disease. And there they compared 8 courses of chemotherapy, AC followed by docetaxel for 4 courses versus TAC for 6 courses. No evidence of an advantage for sequential chemotherapy in the subgroup of triple-negative breast cancer. And finally, the Big 298 is a very interesting study. They randomized patients to a quite extended chemotherapy, A for 3 courses, followed by docetaxel for 3 courses, followed by CMF for 3 courses, versus the sequential control arm, A followed by CMF, AC followed by CMF, or the concurrent docetaxel arm, AT followed by CMF. There was no evidence of an advantage for the primary comparison, docetaxel versus no docetaxel, but the recently presented results updated after 8 years of follow-up showed an advantage for sequential chemotherapy in terms of disease-free survival and also in terms of overall survival if compared with the AT followed by CMF regimen. There was also an exploratory analysis in order to address, it was performed in about 60% of the patients included in the study, in order to address if there was an advantage in selected subtypes of the tumors. And as shown here, there was a trend into an advantage for HER2-positive and triple-negative disease, but this was not statistically significant due to the limited number of patients probably included in this subgroup analysis. So in conclusion, is there a standard duration of therapy in endocrine non-responsive disease? As shown before, many different regimens were used. No clear indication for a particular regimen exists, and no standard duration was identified in clinical studies. However, incremental chemotherapy approaches compared with less extensive therapies were demonstrated to be more effective, particularly in the cohorts of patients with endocrine non-responsive disease. Therefore, I believe it is reasonable to offer conventional dose chemotherapy for 4-6 months in patients with endocrine non-responsive disease. However, it's clear that endocrine non-responsive disease is substantially controlled by the direct effect, cytotoxic effect of chemotherapy. Therefore, for the future, the benefit of extended adjuvant chemotherapy should best be studied in this setting of patients in the absence of endocrine effects of therapies. And this is an example of a study that we carried out, the IBCSG Trial 22, dedicated to initial patients with ER and PGR negative disease that was defined as less than 10% of positive cells by immunohistochemistry. And this study randomized patients after induction standard chemotherapy to a maintenance with low-dose cyclophosphamide methotrexate for 12 months versus nil. However, this study design today is still an old study design because endocrine non-responsive breast cancer is an heterogeneous group of different diseases. And therefore, for the future tailored treatment investigation on tumor subtypes more likely to benefit from extended chemotherapy through international cooperation is key to solidify consensus on how to treat individual patients with endocrine non-responsive breast cancer. And I thank you very much for your attention.